now YouTube on live now. So you
PTS
can,
nama start panalama sir?
Yeah, you can start so now.
Sir, PTS sir? PTS unmute ஆலன்னு நினைக்கிறேன். Okay.
Sir, 8:40 start பண்ணிடலாம் sir.
Start பண்ணிடலாம் sir. சுரேஷ் sir start பண்ணிடலாம் sir. சுரேஷ் இருக்காருன்னு தெரியல. Okay. Yeah. So welcome to all the postgraduates, our TNOA secretary. So we've come back to another session of spine. I know it's a very little bit of gray area and a subject which is a little difficult for the postgraduates to understand. So the scoliosis, as some Dr. Suresh had asked, it might be kept as a long case sometimes. When a spine examiner who is very willing to ask questions in spine, or he's an expert in spine, they might keep. And for DNB exams, it's a very common case, and it can also come as an essay in your theory part. So it's a very important topic and very difficult to understand also. So today we have an excellent speaker, Dr. Sudhir. I've listened to a few of his lectures on scoliosis, really impressed, and he can make it very simple for you to understand. And we've got a moderator, Dr. Phani Kiran, with us today. Phani Kiran is exclusively doing only spine, and he's a senior consultant in Global Hospital in Chennai. So I hand it over to Dr. Phani Kiran to introduce our speaker and carry on the session. Dr. Phani Kiran, over to you. Thanks.
Thank you, sir. Thank you, Dr. Kiru. So I take the pleasure and I thank the TNOA organization for giving us this opportunity to moderate this session. Sudhir, I know him for the last 5 years. He's an excellent teacher. He's studied in institutes of repute where scoliosis is routinely done. He's a post-graduation from Ganga in Coimbatore, and then he has specialized in spine fellowship of National Board from Gangaram in Delhi. And for the past 5 years, he's been working as a consultant and assistant professor in Ramachandra Medical College. What I have noticed is he's got quite a passion for teaching, and especially he emphasizes on inculcating the basics to the PGs. So I welcome all the participants, and I welcome Sudhir to start his lecture on scoliosis. Sudhir?
Thank you, sir. Thanks, Dr. Phani Kiran, for your kind words. So shall I share the screen now?
Yeah, sure, sir.
Yes.
So a very good evening to all present here. And at the outset, I would like to thank the organizing committee of Tamil Nadu Orthopedic Association, Dr. Tirumulai Swami sir, Dr. P.T. Saravanan sir, Professor Singaravadi sir, Professor Vertebral sir, Professor Thanappan and Professor Suresh Kumar, and special thanks to Professor Thirunarayanan sir for giving me this wonderful opportunity to be a part of this great initiative by our parent organization. Actually, this is indeed a very good initiative to improvise the knowledge and share the knowledge amongst our postgraduates. And as you all know, today's topic will be scoliosis. And scoliosis is often considered a highly confusing topic among every orthopedic and spine surgeon, especially it is very scary to the postgraduates. And usually they don't want it to be an exam case or even as a theory question. So today, actually, I'll try to make this concise and short, and I'll try to discuss the basics of scoliosis and also about, the very basics of treatment and management to give you an idea about the various terminologies basically that is used in scoliosis and the concepts, and of course the principles of management of scoliosis. So I think we'll stop after each session and each topic, and then we'll have 3 to 5 minutes of discussion, and then we'll proceed further. And you need not get you need not get worried that it will be very boring and it will be too hi-fi. I'll just stick on to the basics so that it will be interesting as well as it will be educated to all of you. So I hope you will all enjoy and you will all benefit from today's session. So let's start now with the topic. So scoliosis as such is defined by the SRS, that is the Scoliosis Research Society, as a three-dimensional rotational deformity, which is a deformity in the frontal plane, coronal plane, and the sagittal plane. And it's actually a lateral curvature, and it is usually greater than 10 degrees in the coronal plane as determined by the Cobb's angle. So we'll come to what is Cobb's angle later in these slides. So the definition as such is lateral curvature greater than 10 degrees. Scoliosis word was derived from a Greek word which means crooked. So that is the actual meaning of scoliosis. So then coming to the various types of scoliosis. Scoliosis can be divided into various types based on the etiology as compensatory scoliosis. Sometimes there will be limb length discrepancy due to some hip pathology or due to any other pathology, and the spine will compensate for this, and that is called as compensatory scoliosis. Or it could be congenital scoliosis, which is further divided into failure of formation, failure of segmentation, or mixed type, which includes both. The most common variety of scoliosis which we clinicians come across and which you will get in your exams is idiopathic scoliosis. So idiopathic scoliosis means that the cause or etiology is unknown. It could be genetic, environmental, or biomechanical. There are various factors which plays a role. So that part of scoliosis is called as idiopathic scoliosis. They are further divided into three categories, three types based on the age of onset. This is very important. So infantile scoliosis is the one which presents less than 3 years of age. Juvenile is the one which presents 3 to 10 years of age, and adolescent idiopathic scoliosis, which is common among these three, presents greater than 10 years of age. Next comes the neuromuscular type of scoliosis, which could be divided based on whether it is neuropathic type or myopathic type. The last one is scoliosis, which is associated with syndromes like Marfan's, Ehlers-Danlos, spinal epiphyseal. I mean, there are various syndromes, and any scoliosis which is associated with those syndromes are called as syndromic scoliosis. Today's talk will be predominantly covering the basic points and terminologies about idiopathic scoliosis. We'll see few slides about congenital and neuromuscular scoliosis because I don't want you to confuse you much. Again, scoliosis can further, it can be classified in another way based on the age of onset, because people thought that when you treat scoliosis, the management depends predominantly on the age of onset. It can be divided as early onset if it is less than 5 years, and late onset scoliosis if it is greater than 5 years. Why this is important is the surgeons and those who researched on scoliosis, they found that if you undertake any surgery at an earlier age and if you fuse the spine, what will happen is it will restrict the growth of the thoracic cage, which in turn will restrict the parenchymal and alveolar development. Usually the maturity of alveoli takes about 8 years of age, the entire maturity. So you have to wait till 8 years of age till you do any definitive fixation for these patients. So this was the concept by which they divided it into early onset and late onset. This is a chart which you can see on the second page of Campbell. I just wanted to put this and highlight very few points. You need not see all the points in this. Just see the boxes alone. Infantile scoliosis is common in male, or it is equal or it is common in male. Whereas the juvenile and adolescent, the adolescent is the most common type, as I said, it is common in females. Similarly, the type of curve, right thoracic is common in adolescent, whereas left thoracic is common in infantile. And again, surgical treatment, usually if the child is less than 8 years, as I already told you, based on the thoracic cage development, instrumentation can be done, but without fusing the spine if it is less than 8 years. And after 8 years, it should be spinal fusion. And after 11 years, it is posterior spinal fusion. I just wanted to put this particular table because it was given in Campbell. We'll discuss the principles of treatment in the later slides. The one point which you have to know is commonest type is adolescent idiopathic scoliosis, right thoracic females. These 3 points are very important. So coming to history, scoliosis may be kept as a short case, if at all, if the examiner is very much willing in discussing some spine case, and if you have scoliosis at the time of exam, it may be kept as a short case, very unlikely to be kept as a long case. But if you are able to point out the basic points and if you are able to discuss these points, it is more than sufficient in the exam. So any scoliosis, you have to ask the onset, duration, and progression of the scoliotic curve. Usually the informant will be one of the parents. And if it is a mother, especially in females, the reliability will be good. Usually they'll say that the curve onset was about 6 months or 1 year, but usually it is because they will not have checked the back often, and when the child undresses himself or herself, they will notice the scoliotic curve, and that's all they'll come to know the presence of scoliosis, or there will be drooping of shoulders. So this will be the usual presenting complaints. And duration is very important. The most important history which you have to ask if it is presenting, especially in younger kids, is about the natal, antenatal, and postnatal history, just like in any other congenital deformities of the limbs. So that is very, very important. The next most important history, especially in females, is history of menarche, whether the patient, whether the subject has attained menarche or not, because that is very, very vital point in the management of these patients. Again, the next most important point is pain. Usually scoliosis is a painless condition, and the patient comes to you for cosmetic deformity, especially adolescent idiopathic scoliosis. If a patient comes to you with complaints of pain, which is aggravated in the night, then you have to look for something else, which is usually osteoma. They present with painful scoliosis, or any other tumor can also present with painful scoliosis. That is very, very important. So this history is very important. And as like in any other spine case, you have to ask for the neurology of the patient, whether there is any weakness or numbness. Again, this is very important because adolescent idiopathic scoliosis, they don't present with neurological deficit. Whereas in case of congenital scoliosis, they may present with weakness or numbness, or in cases of syndromic or neuromuscular scoliosis, there may be neurological involvement. All these things are very, very vital in deciding your treatment protocol. Coming to the examination, it is just like any other examination of, of any case, but you have to start with general examination. The most important thing in scoliosis, the examiner will expect you to comment on the neurocutaneous markers. You have to know certain neurocutaneous markers, which is very, very important. It could be tuft of hair, it could be myelomeningocele or Shaw-green patch, cafe islet spot, dimple, or ash leaf spots. These are some telltale signs that something is wrong in the spine. There may be some underlying spinal dystrophism, kind of like conditions like diastrophatomyelia, which means there is a split in the spinal cord, or spina bifida occulta, whereas the posterior elements of the spine will not be fused. And all these things are usually associated with scoliosis. And the next thing, usually in examination, they will not expect you to know the entire TNOA staging system, but you should be aware of this TNOA staging system based on breast, pubic hair, genitals, and in males and females. And they have 5 staging system. You should have an idea about this. Some examiners may ask, how did you diagnose the skeletal maturity of this patient clinically? If they ask that question, you should be able to answer that. I use TNOA staging system to stage the age of the patient. So that is very important to know about the maturity of the child. Now coming to the clinical examination of spine per se, the first and foremost thing is, suppose if you are suspecting scoliosis, then the most important thing for inspection is you have to stand behind the patient. That is first and foremost. So you have to start by saying that on inspection, by standing from behind the patient, sides and front, then you have to start your examination finding. You have to look from head to toe. First and foremost thing is whether the head is centered over the pelvis or not. How do you look in inspection? The head should be centered over the gluteal cleft. If possible, most of the times you have to undress the patient and examine the patient with underwear. And if it is a female child, you have to ask the sister and the parent to stand nearby, and then you have to examine. Why it is important? Head centered means it is a compensated scoliosis, which means if there is a curve present which is obvious, there may be another compensatory curve which is maintaining the head and the trunk in position with the pelvis. So that is very, very important. Level of shoulders, very, very vital point. So the level of shoulders usually will be elevated on the convex side of the curve. You can see in the clinical example as well as in the schematic diagram, you can see the convexity of the curve is on the right side and the right shoulder is elevated. Suppose if you are seeing a curve very prominently on the right side with the convexity on the right side, but if the left shoulder is on the is elevated, it means there is a proximal thoracic curve which is above the curve, which is above the main curve. So that is very, very important not to miss this particular point. So shoulder will be elevated on the convex side most of the times. Again, the level of scapula, the spine of scapula, angle of scapula will be elevated on the convex side most of the times. The level of iliac crest will be elevated on the convex side of the compensatory curve. So as I said, when there is a main curve, usually there will be a compensatory curve at the bottom, which is the lumbar curve. So the iliac crest will be elevated on the convexity of the compensatory curve. So that is, again, it is important point. The next thing which you have to look for is the location of the curve. So whenever you are examining a patient, inspection wise, you have to look for the location. For example, in the with the clinical example towards the left side, you can see a curve which is located on the thoracic area predominantly, and the apex of the curve is approximately corresponds to the inferior angle of the scapula, so which is approximately T7, T8. So in inspection, it is usually enough if you say an approximate location of the curve. So it is a thoracic curve with an apex over T7 or T8. And if there is any other curve which is visible, obviously, then you can comment. If there is a lumbar curve visible, then you can comment that there is a lumbar curve which is also present. Then you have to look for, again, type and locate. Then you have to look for the arm thorax distance. Why is this important? You can see here. On the convexity of the curve, the arm thorax distance will be absent. It is just common sense. As the trunk gets shifted to the towards the convexity of the curve, obviously the distance between the arm and trunk will be, arm and the thorax will be reduced, whereas the distance will be more. This indirectly signifies the severity of the curve. Suppose the arm thorax distance on the concave side is more, it means the curve is a bigger curve. So this you can diagnose, and then you have to stand in front of the patient. If possible, you can look at the interpupillary angle, which means that if there is any tilt or not, and the shoulder balance. That is, as I said, it is very, very important. Then comes the most important thing, which is the sagittal alignment. So any case of scoliosis, it is mandatory to examine the patient by standing from the side, and you have to look for the kyphosis and lordosis. You have to look whether there is any exaggerated thoracic kyphosis or normal kyphosis and lordosis. This again is very, very important. So one of the most common questions which is asked in the exam is, what is Adams forward bending test? See, Adams forward bending test is usually used for, it is used as a screening test, especially in schools, wherein you can diagnose scoliosis by just asking the patient to bend forwards with both the palms together and elbows extended and with knees in extension. And they should be bending forwards. You should stand behind the patient and you should bend down at the level of thorax to avoid any parallax error, and you have to look for the rib hump. So if there is a rib hump present, it means the child has scoliosis. Some surgeons feel that it also can be used to determine the rigidity of the scoliotic deformity. There may be scoliosis which is visible when the patient is standing erect, and when the patient bends, sometimes the scoliosis may not be very obvious. So it shows that the curve is quite flexible and the rib hump is not prominent, or the deformity is not very prominent. So the basic mechanism of this is, since it is a three-dimensional rotational deformity of the spine, as the spine and the vertebra rotates, the rib gets pushed posteriorly on the convex side. So it becomes prominent on the convex side. So it is important clinically, as well as it is important for management, because some children may come with complaints of prominent rib hump as their primary complaint. So our aim of surgery or treatment should be reducing the rib hump rather than concentrating on rest of the things. So this is Adams forward bending test. Again, scoliometer can be used to know the amount of truncal rotation and the deformity which is present. Usually scoliometer will be used by specialists, and it is not very commonly used in the normal outpatient clinics. And this is how it is used. You can place the scoliometer over different places of the thorax, just in the position of Adams forward bend test, and you can look for the degree of the curve. The examination of a scoliosis patient is not complete without gait, hip joint examination, limb length measurement. It is very, very vital. So whenever you get a scoliosis, you always measure limb lengths. It could be compensatory. So how do you differentiate whether it is because of limb length? So if a patient is standing and if you are able to visualize a scoliotic curve, then make the patient sit and then you examine. If the scoliotic curve gets corrected, it could be a compensatory curve because of various other phenomena, or predominantly limb length measurement. And neurological examination. So any spine examination is incomplete without neurological examination. As I pointed out earlier, usual cases of adolescent idiopathic scoliosis, the neurology will be normal. The next common condition which gets confused with scoliosis is something called as list. It is otherwise called as sciatic list. So what are the differentiating features? In case of scoliotic curve, usually, as I said, it is a right-sided thoracic, usually, commonly. Whereas list, it depends on the side and site of pathology. Why does list occur? Whenever there is compression of a particular nerve root because of disc prolapse in the lumbar region, the body tends to compensate or give some space for the nerve, as a result of which the trunk shifts towards one side. It is just like a boil under your axilla. Whenever there is a boil, we tend to lift our arm up so that there is some space for the axilla, for the boil, and there is no, so that the pain is reduced. The same mechanism. In case of scoliosis, the shoulder will be usually balanced over the pelvis, whereas in sciatic list, there will be complete truncal shift. The pelvis will be here, the trunk will be totally off-center. And pain will be absent in scoliosis, whereas it is usually present in cases of sciatic list, and it will be a radicular pain because there will be compression of a nerve root. Deficit, again, it will be absent in scoliosis, whereas in case of list, it could be present. Radiologically, if you see, the rotational element will be absent in list. It will be a gross truncal shift. You can clearly see, if you draw a line from the center of the S1 spinous process, there is complete truncal shift, and there is no rotation of the pedicles. By the term rotation, I mean, you can see, clearly visualize the two eyes of the vertebra, which is called as the pedicle. If it is equally visualized on both sides, it means that there is no rotation. I think if there is any doubt in examination and history, we can stop for 2 to 3 minutes, and then we can proceed with X-rays, because X-rays is going to be a little bit confusing, and may have to spend some time on X-rays, and it is the most important thing in scoliosis.
Yeah, Sudhir, so
Yes,
it was so far it's an excellent introduction into the diagnosis, definition, and the types. You have clearly defined in a simple way, what are the most common types of scoliosis, the etiological as well as age-related, based on the age of onset. If there are no questions, I would like to just ask you one question. What is the importance of why is it important to diagnose early onset? Why did we define an early onset scoliosis versus regular scoliosis?
Okay. Usually the lung maturity, the alveolar maturity takes about 8 years for it to get completed. So whenever we come across scoliosis at an early age, there will be gross abnormality of the thorax because of the rotational deformity, as a result of which the rib cage will get distorted, and the space for the lungs to expand and the alveolar maturity will be grossly reduced. And these patients, they usually present with severe breathlessness or breathing difficulties also. It is kind of a restrictive type of disease because of lack of space for them to develop. And again, treatment wise, when we come across these kind of patients, it is very, very vital for allowing the spine to grow till the alveolar maturity is obtained. If we intervene earlier and if we try to fuse the spine before 8 years of age, it can result in gross pulmonary functional deficit for these children. So that is the basis for both for diagnosis as well as for treatment purposes, the early onset and late onset.
That's an important point for the PGs to understand. Why do we define early scoliosis, early onset? Dr. Sudhir has clearly explained. Because these kids develop restrictive pulmonary problems and cor pulmonale, and they also have a shorter lifespan if it is untreated in severe cases. So there's a question, just a couple of minutes we'll spend on questioning. Why idiopathic is more common in females?
Yeah, as I told, there are various factors which plays. The common ones are the genetic factors, and environmental factors, and the developmental factors. Usually, whenever there is a growth spurt in children, girls attain maturity at an early age, about 1 to 2 years earlier than boys, and they present earlier. However, the cause for common. Why it is common in females? There is no specific cause. It could be underlying hormonal issues. It could be genetic issues. And there are few studies which have clearly said that hormonal factors play an important role in progression as well as the occurrence of curve in females.
Yeah, that's right. So as the diagnosis itself suggests, idiopathic, which means the cause is still not clear. So we don't know the etiology, which is proven that it is that is causing the scoliosis. So what is noticed is it is more common in females. There's another question here, Sudhir. What are the things needed for scoliosis examination, like things like scoliometry, etc., in practical exam for the PGs?
One of the most important things that we have to, that's a very, very vital question. You have to have a plumb line. Usually when we went for our exams, we used to carry that plumb line, which is available in the hardware shop. So it is better to have a plumb line wherein you can place over the center of the occiput or the center of the C7 spinous process, and you can see whether the head is centered or not. Inch tape is very, very important. And for neurological examination, you need tuning forks, you need the knee hammer with the blunt point, you need a wisp of cotton to look for sensory examination, rest of the other things which we have discussed in our earlier classes for neurological examination. As such, one important thing which you need is the plumb line, and if you are able to get a scoliometer, it is okay, but it is definitely not mandatory. And even if you don't have a scoliometer, examiners, they don't ask for it in the exams.
One last question, Sudhir, before we move on for X-rays. What is the importance of the examination of reflexes, the tendon reflexes as well as abdominal reflexes in the examination of a scoliosis case?
Yes. Whenever there is some abnormality in the reflexes, like there is an exaggerated reflex or absent abdominal reflex, it indicates that there is some kind of spinal anomaly which is there, and there could be some tethering of the cord, or it could be some compression of the cord because of diastematomyelia or some other underlying spinal dystrophism conditions, which can present as exaggerated reflex in these patients.
Good. Okay. One question before examination. What is the Adams test only applicable for thoracic scoliosis?
Yeah, Adams test is predominantly for thoracic scoliosis because it looks for the rib hump. However, whenever there is a lumbar scoliosis, there can be a compensatory thoracic scoliosis which occurs. Again, that can be diagnosed with Adams forward bending test. However, it was introduced and it is commonly used for diagnosing thoracic curves.
Good, Sudhir. I think we'll go ahead with the X-rays.
Yeah.
Sudhir, I just have one doubt.
Yes,
is
sir.
it possible to clinically say which is the prominent curve, which is the compensatory curve? Clinically.
Yes, sir. Yeah, clinically, usually the larger curve is the major curve is will be the prominent one. Like for example, if a thoracic curve is very big, it is just by inspection. We'll not be able to say clearly, but definitely we'll be able to know which is a major curve or a minor curve.
Okay, yeah. Please proceed.
Yeah. So the most important thing in scoliosis is X-rays. So there are various confusing terms, and the moment a scoliosis X-ray is being put, everyone will get irritated to read the X-ray. So, however, there are certain important points before going on to the X-ray. You should always have a full-length X-ray which covers from C7 to femoral heads as far as possible. At least from C7 to S1, you should be able to visualize both SI joints and S1, S2 spinous processes. That is very, very important with rib cage, and usually it is 14 into 36 inches cassette with patient in standing position. Again, a full-length lateral X-ray starting from C1 to the bilateral femoral heads, because of late, there are something called as sacropelvic parameters. In order to measure those parameters, this is very, very vital. And to discuss and to look for the sagittal alignment, this is very, very important. There are various other parameters which we will be discussing later. Again, it is a standing view. The most important X-rays, apart from these two routinely done X-rays, are the side bending films. So you ask the patient to stand and bend towards right side and left side to as much as extent as possible, and you take an AP view. This is very, very important. I'll tell the importance in the later slides when I discuss about classification and the criteria. So these are the examples of side bending views. Traction film, few centers they do traction film. I routinely do a traction film for all my scoliosis patient. You just ask the patient to lie down, and we used to pull the hands of the patient and the legs of the patient. One of the assistant will pull, and then AP X-ray will be done. Usually it will be done in a lying down position. It will give us a clear idea that how much amount of correction that you can get after anesthesia, and it gives much more value than side bending views. However, it is not routinely performed in all the institutes. Side bending view is mandatory. Bolstered bending film is used in certain places in the world, but you should know what is that. It is just by placing a fulcrum or a bolster over the convexity of the curve in a lateral position, and then you take a AP view. Stagnera view, very rarely we perform. After the advent of CT, we can view the individual anatomy of every vertebra using CT. Since it is given in Campbell, I just want to mention this. It is to eliminate the rotational component of the curve so that accurate measurement of the curve size and the vertebral anatomy can be visualized. It is actually an oblique radiograph with the cassette parallel to the medial aspect of the rib prominence, and the X-ray beam is at right angles to the cassette. So that is how you can clearly see in the example. So basically you're nullifying the rotation and you're looking the vertebra. That is Stagnera view. Now coming to various parameters. The first and foremost thing is to look at an AP view. Whenever you are taking a scoliosis X-ray, it is like you are viewing the patient from behind. So, not like you have to place the X-ray in not normal position like we are viewing. You have to tilt the X-ray so that right side of the patient should be your right side. I think you all got my point. Normally, we look at the X-ray like this and we say our right side will be patient's left. Whereas when you are reading scoliosis X-ray, you have to turn the X-ray and then you have to read the X-ray. The first and foremost point is you have to draw two lines in the AP view. First one is CSVL, which is central sacral vertical line. As the name indicates, it is a line drawn from the center of the sacrum, that is from the S1 spinous process, and it has to go vertically above. The next line is C7 plumb line. That is, you draw a line from the center of C7 vertebra and you draw vertically down. So, most of the times in a normal individual, both of these lines will be over one another. There won't be any discrepancy. That means CSVL will merge over C7 plumb line. If there is a difference of greater than 2 centimeters between these two lines, it means there is some truncal shift happening and the curve is decompensating. That is called as coronal decompensation. So this is very, very important. If the CSVL and the C7 plumb line doesn't coincide, it means there is coronal decompensation. So this is very, very important. The next important thing for these lines is the apical vertebral translation, AVT. It is measured from the C7 plumb line. You are drawing a C7 plumb line, and the apical vertebra, that is the vertebra which is lateralmost vertebra in the curve. The distance between these two is called as the apical vertebral translation. So that is measured from these lines. Then coming to sagittal balance, you draw a C7 plumb line from the center of C7 vertebral body. In normal individuals, it should pass within a few millimeters anterior or posterior to the posterior superior corner of S1. That is either 5 or 5 on this side. If it is passing beyond that 5 centimeter, it means it is a positive sagittal balance or negative sagittal balance. Usually, if it is a negative sagittal balance, that is, if it is passing behind the femoral head, it is good. The more it goes front, it means it is not a good sign. That means the curve, the individual is falling forwards or sagittally decompensating. How do you assess rotation? See, the rotation thing is most important thing in scoliosis. So how do you measure? There are two methods. The commonly used method is Nash and Moore method on the basis of asymmetry of pedicles. As I pointed out earlier, in a vertebra in the X-ray, you will be able to see two eyes. That is the pedicle, and it should be equal on both sides, and it should be of equal size. When one eye or one pedicle is small and the other is getting bigger, it means there is a rotational component, and it is graded as grade 0 to grade 4 based on the position of the pedicle. So the most severe type is only one pedicle will be visualized and it will be passing to the opposite side. So it means there is a complete rotation of the vertebra. So the entire vertebra is getting rotated. So you will be able to see only one pedicle end on view. and the two, it is crossing the midline. The other method which is mentioned in Campbell is pedioral method, whereas there is a template and you place the vertebra over that. However, it is not being used very commonly for clinical practices. You can just know the name. Coming to the next radiological point, which is the rib vertebral angle difference. So this concept is for infantile and juvenile scoliosis. It doesn't have any role in in adolescent scoliosis. It's predominantly for infantile and juvenile to know whether these curves will progress or not. So this was actually described by Mehta. She actually herself had scoliosis and she described this angle. So it is the angle between a line which is drawn perpendicular to the end plate of the apical vertebra, the red line which you can see in the diagram, drawn, and the green line which is drawn along the center of the rib. The angle made between these two lines on the on the apical vertebra is called as the rib vertebral angle. And the difference between the convex side and concave side is called as the difference between the angle. If the difference is greater than 20 degrees, it means those curves are bad curves and the chances of progression is high. And if it is less than 20 degrees, you can observe those patients and the chances of progression is relatively less. Another concept which was described is rib face. Again, you look at the apical vertebra and the convex side. If the convex rib does not overlap over the vertebral body, it means it is in the phase 1. If it is overlapping, it means phase 2. This is again because the curve is very severe, the rotation is very severe, the anomaly is so severe that the rib actually surpasses the vertebral body and actually overrides the vertebra. So this is phase 2, and any child with phase 2, rib phase 2 has a higher propensity of curve progression. So basically, in infantile and juvenile, rib phase 2 and RVAD greater than 20 degrees, it means the curve progression will be more. The next thing which you have to look is riser's grade. This is important to know the skeletal maturity of the patient. It is based on the ossification of the iliac apophysis. It is graded from grade 0 to grade 5. Grade 0 is absent. 1 is 0 to 25%. It is from lateral to medial. And grade 4 is 100%, 75 to 100%. You have to know the difference between grade 4 and grade 5. Grade 4 is 75 to 100% of apophysis which is present. Grade 5 is fusion of apophysis to the ilium. So if you are seeing an X-ray of pelvis and if you are not able to see any apophysis, it could be grade 0 or it could be grade 5. In those conditions, you have to look for the triradiate cartilage to look for skeletal maturity. Yeah, this is an example. You can see it is about grade 2 to grade 3, starting of grade 3. You can see from lateral to medial. Now coming to few terminologies, I'll try to make it very simple. The first and foremost important terminology is end vertebra. Why is this important? We are dealing with the curve. Scoliosis is nothing but a curve. A curve should have end at the top and end at the bottom. So end vertebra is a vertebra which tilts maximally into the concavity of the curve. Our right side is the convexity and our left side is the concavity. So you draw lines along the end plates of these vertebrae and usually they will converge towards the concavity because the curve is nothing but it is an incomplete form of circle. So when you draw lines, it will converge to one center point. The next intervertebral space below the inferior end vertebra or above the superior end vertebra, it is wider on the concave side. I'll just show you the diagram. See like this. If you draw lines along the end plates, the line should be convergent on the concavity of the curve. If you see the pink color arrow mark, the line drawn along the end plates, you can see it is converging on the opposite side, which means the curve has ended and a new curve has started at the bottom. So the end vertebra is a vertebra which tilts maximally into the concavity of the curve. It is the least rotated vertebra because it is the end of the curve. So obviously it will be least rotated vertebra. The next one is the apical vertebra. It is the most horizontal and the most laterally deviated apex of the curve. So the vertebra which is at the apex of the curve is called as the apical vertebra. and it is the least tilted, obviously, because it will be horizontal and laterally tilted. It is the center part of the curve, and most rotated because it is it is in the center of the curve. So it will be most rotated and horizontally displaced. That is called as the apical vertebra. The apex of a curve can be a vertebra or an intervertebral disc space also. For example, in this X-ray, it is actually an intervertebral disc space, not a vertebra per se. Stable vertebra. This is very, very important for treatment protocol. So how do you determine? Again, draw CSVL, central sacral vertical line. The vertebra which is most closely bisected by the CSVL in the AP view is the stable vertebra. And it means it is situated over the center of the sacrum. That means it is in the center or stable zone of the pelvis. It was actually described by Harrington. Stable zone is zone which is horizontalized over the pelvis, and any vertebra which is bisected closely by the CSVL is called as the stable vertebra. In this case, you can see the pink arrow. The vertebra below is not bisected, whereas the vertebra above is relatively bisected by the CSVL. So we can take that as the stable vertebra. Neutral vertebra, name itself denotes that vertebra with no rotation. So in AP radiograph, the spinous process usually is located between the pedicles. You can ask a question. You said that end vertebra is the least rotated vertebra. So end vertebra and neutral vertebra, are they same? No. Sometimes the end vertebra and neutral vertebra, usually they will be 1 or 2 levels above or below. That is because there may be some amount of rotation which is happening in the end vertebra, whereas the neutral vertebra will not have any rotation at all. This example, you can see the pedicles and you can see the spinous process. So the pedicles in the vertebra above and below, they are not uniform, which means there is some rotation. Again, the spinous process is tilted to on either sides in the vertebrae above and below, whereas in the vertebra marked by the arrow, you can see the pedicles very clearly and the spinous process very clearly in the center. It means that is the neutral vertebra. Curve location. How do you define a curve? Whether it is a cervical, cervicothoracic, thoracic. This you have to by heart. We don't have a choice. This is based on the Scoliosis Research Society definition. So if the apex is present between at C7 or T1, it is called a cervicothoracic or proximal thoracic curve. The classical commonly seen thoracic curve has an apex between T2 and T11-12 disc. Thoracolumbar if the apex is at T12 or L1. Lumbar if the apex is between L1 to disc and L4. Lumbosacral L5 or S1. This we have to by heart, and there is no other go. And this is very, very important. We'll all be very familiar with this Cobb's angle. It is the angle formed by 2 lines. One parallel to the end plate of the superior vertebra, and the other one is through the inferior end vertebra. If they both merge together, the angle will be determined by that. If they are not bisecting each other, then you have to draw 90-degree angle to these lines and perpendicular to these lines, and the angle between these perpendicular lines is the Cobb angle. This is the original way of measuring Cobb's angle. Now comes slightly confusing part. What is a major and minor curve? Major curve is a curve with largest Cobb, no doubt. And usually, most of the times, it will be a structural curve. Minor curve is a curve with all other curves, which structural criteria apply. Okay, which means suppose if you have 3 curves in a patient, one curve is 60-degree, other curve is 40, other curve is 20. There is no doubt. Major curve is the 60-degree curve. That's it. But the confusing part is here. What is structural curve and a non-structural curve? So the curves which do not correct less than 25 degrees on side bending view, it is called as a structural curve. So that is the importance of side bending view. So you again measure the Cobb's angle from end vertebra to end vertebra in a side bending view. And if it is more than 25 degree, that curve becomes a structural curve. Again, going to the same example, 60-degree curve, 50-degree curve, 20-degree curve in a patient. 60-degree curve, if it becomes 50-degree on side bending, it is a structural curve. 40-degree curve, it becomes 30-degree on side bending. Again, it is a structural curve. Though it is a minor curve, it is a structural curve. Okay. Suppose the 60-degree curve which is a major curve on side bending, becomes 20 degrees, highly flexible curve which becomes 20 degrees, it is a non-structural curve. So I think you have to be very clear about this point. And the curves on side bending, which comes to less than 20 degree, 25 degree, it is a non-structural curve. Non-structural curves are usually referred as compensatory curves. And over time, they may become structural, because if you don't intervene, they may become rigid and they may become structural at later point of time. I'll just show a clinical example. This is one of my patients. You can see there are three curves, as I said. One is 100 degree, the other one is 54, the other one is 47. The 100 degree one is the thoracic curve, and the 47 is the proximal thoracic curve, and 54 is a lumbar curve. There is no doubt, major curve is thoracic curve. All the other curves are minor curves. So it is a proximal thoracic, lumbar, both are minor curves. Now, structural and non-structural. If someone shows you this X-ray and asks you which is a structural curve and which is a non-structural curve, immediately you should say politely, sir, I would want a side bending radiograph to know which is a structural and non-structural curve. That should be the answer. And you have to go for the side bending views. If you can see, the topmost diagram is a side bending view. On the left side, you can see the lumbar curve has corrected to 5 degrees. From 54 degrees, it has corrected to 5 degrees. The proximal thoracic has corrected from 43 to 41, and main thoracic from 100 to 99, which means what are the structural curves? Thoracic and proximal thoracic becomes the structural curve, lumbar curve becomes non-structural curve. In this example, though the lumbar curve is greater than proximal thoracic curve, since in side bending the lumbar curve comes less than 25 degrees, it is called a non-structural curve. You can ask the question why 25 degrees was utilized. See, various researchers, they undertook years and years of follow-up, and they analyzed various curves, and they found that based on fusion, if they fuse the curves, if they didn't fuse the curves greater than 25 degrees, eventually they decompensated and they become structural, and the patient again came up with deformity. So that was the reason why 25 degree number was chosen based on intensive literature search. Coming to the last,
Sudhir,
yeah.
Sudhir, just a second. Before you move on to the classification.
Yeah, I just
wanted. Just wanted to summarize. You clearly excellent in an excellent way. You have explained how to do a radiographic analysis of scoliosis. To broadly summarize again, what I would want the PGs to understand is that what we do in radiographic analysis is to have these full-length standing X-rays, as was shown. And the first thing that Sudhir showed, Dr. Sudhir showed, was to show that we see the global alignment. We see by drawing the central sacral lines and the sagittal profile to see the thoracic kyphosis and lordosis, whether the patient is balanced or not. So that is the initial thing that we see. And also an X-ray will give us an idea whether there is any congenital component or a component of other neuromuscular causes like a neurofibromatosis. So that is alignment, global alignment is one thing. And then he explained about how to see the rotation, severity of the curve by measuring the rotation, as well as by after defining the end vertebrae to measure the Cobb's angle. So these are the things that we do to have an idea about the severity of the curve of the scoliosis, and also the major and structural curves and non-structural curves. So there are certain things we do to analyze the patient and analyze the severity of the curve and classify, and there are certain things we measure to plan the treatment. So these two things you should understand. If for the PGs, I think if you can just understand the measurements that are done for global alignment as well as to assess the severity of the curve, that should be enough. But you also should know what are the important vertebrae, like the end vertebrae, the neutral vertebra, and the apical vertebra. So just to make it clear for you, don't get overwhelmed or confused. These are very simple things if you try to just look and think through, quite logical and easy to understand. Okay, Sudhir, we can proceed.
Yeah. So coming to the classification part, I know it is going to be much more difficult now, but I'll try to make it very simple. So the classification, initially the one classification which was followed very commonly for treatment and to classify the curves was King's classification. But nowadays we are not using King's classification very commonly, but again it is given in Campbell, so you should know what is King's classification. They're basically divided into 5 types. First 2 types are double curves, and both the double curves, they cross the midline. The first type, the lumbar curve is more than the thoracic curve, which means the thoracic curve is much more flexible. In the second type, again there are 2 curves. However, the thoracic curve is larger and stiffer than the lumbar curve. Type 3 is predominantly a thoracic curve, which we usually see. That is the right-sided thoracic curve is type 3. Type 4 is a long thoracic curve. This particular type is quite rare and it is not being properly incorporated in the recent classification system, and it poses a great challenge for the treatment modality. It is a long thoracic curve where L4 tilts into the concavity of the curve, which means L4 also becomes a part of the curve. And type 5 is the thoracic curve and with the proximal thoracic curve, which means that T1 tilts into the curve. So basically type 1 and 2 are double curves. Type 1 is lumbar more than thoracic. Type 2 is thoracic more than lumbar. Type 3 is a straightforward, only thoracic curve. There may be some compensatory curves, but thoracic curve is the major curve which shifts offline. Type 4 is a long C-type thoracic curve. Type 5 is a thoracic with a proximal thoracic. To confuse you further, and to confuse all of us further, came the Lenke's classification system in the early 2000s, and it revolutionized the treatment modality and the understanding of scoliosis. So it is mandatory for you guys to by heart this type of this classification. Basically, it is 3 parts. One is curve type. Second is modifiers: lumbar spine modifier, thoracic sagittal modifier. So the curve types can be divided into 6 types. So basically you have to divide into 3: proximal thoracic, main thoracic part, and the thoracolumbar or lumbar part. Type 1 is nothing but a main thoracic curve. See, main means only the main thoracic will be a structural curve. That is, in the side bending view, the angle will be greater than 25 degrees. The proximal thoracic and thoracolumbar will be less than 25 degrees in side bending view. Type 2 is double thoracic. That means there will be a proximal thoracic component and a main thoracic structural component. Type 3 is double major. The difference between double thoracic is there is a proximal thoracic and main thoracic. Double major is main thoracic and a thoracolumbar curve. Type 4 is triple major, which means all 3 curves will be major. That is, all 3 curves in the side bending views will be greater than 25 degrees. Type 5 is predominantly a thoracolumbar or a lumbar curve. Main thoracic and proximal thoracic curves, if present, it will be less than 25 degrees in side bending view. Type 6 again is a thoracolumbar lumbar plus a main thoracic. See, this you have to differentiate between type 3 and type 6. In both these things, both main thoracic and thoracolumbar are structural curves. But the main difference is in type 3, the main thoracic will be a major curve. That is, by Cobb's angle measurement, main thoracic will be, so for example, 60 degree, thoracolumbar will be 40 degree. Whereas in type 6, main thoracic will be 40 degree, thoracolumbar will be 60 degrees. But both will be greater than 25 degrees in the side bending views. That is very important. So again, based on the structural criteria, we have discussed this. We have discussed this slide also. So the red ones means structural curves, and type 3 and type 6 difference you should know. Okay. Then comes the lumbar spine modifier. They divided lumbar spine into 3 types: A, B, and C. It is based on the relationship between the central sacral vertebral line to the apex of the lumbar curve. If the central sacral vertical line passes between the pedicles of the apex of lumbar curve, it is type A. If it passes or just touches the pedicle, it is type B. And if it is completely off medial to the lumbar curve, it is type C modifier. You have to by heart this classification. There is an in-depth explanation of why these modifiers are there, what is the significance of A, B, C, and why each type has these three modifiers. But that is beyond the scope of this talk. But you have to understand the classification and try to by heart this. Type, the next comes the thoracic sagittal profile modifier. You should understand one thing. In idiopathic scoliosis, especially in adolescent idiopathic scoliosis, it will be associated most of the times with hypokyphosis of the thoracic spine. Usually, congenital scoliosis will be associated with hyperkyphosis. That is why most of the cases of congenital scoliosis will be termed as kyphoscoliosis. Whereas idiopathic scoliosis, most of the times it will be a hypokyphosis. So it is called as hypo if the angle is less than 10 degrees, and it is 10 to, sorry for that, it is not CSPL to lumbar apex, it is the angle, Cobb's angle in the sagittal profile, and hyper if it is greater than 40 degrees. You should just know the name of another classification, which is recently being discussed in all forums throughout the world, and it is actually better than, personally speaking also, I am trying to use this classification of late, and it is slightly better than Lenke's classification because it is quite safe in deciding the treatment and to prevent decompensations. It is called as Peking University Medical College classification, and now they have recently modified in 2019, so it is called as modified PUMC classification. I'm not going into the details. You need not know the entire classification system also because it is quite confusing. So you just know the name. So when they ask about what are the classification systems which you know for scoliosis, you can say King's classification, Lenke's classification, most important because that is the one which is currently followed everywhere. And you can comment, you can just name modified PUMC classification. If someone asks what is that, you can say that you don't know the in-depth detail of this classification, but however you can mention the name. So this is the basic outline which I have prepared for myself from various textbooks and other things for the postgraduates to understand. So I usually discuss this with my PGs when I discuss scoliosis. Whenever you come across a case of adolescent idiopathic, you have to underline the word adolescent idiopathic scoliosis. You can divide the patients into skeletally immature or skeletal mature. The skeletal maturity depends on various factors like Reiser's grade, menarche, Tanner staging, triradiate cartilage, and olecranon ossification, etc. But the most important thing is Reiser's sign, menarche, and triradiate cartilage.
Sudhir, can I interrupt you here?
Yes.
So two things I just want to ask for the benefit of PGs. When there is the main idiopathic scoliosis is right thoracic. So suppose if there is a idiopathic looking curve, but it is left thoracic, what does it indicate and what would you do differently?
Yes, it's a very important point. Any case of scoliosis, it is mandatory to look for MRI. The question, the answer to the question is, if it is going to be a left-sided curve, it is not very common. So you have to look for other congenital anomalies of the spine and spinal dystrophisms, and you have to do MRI scan and CT scan for all these patients. MRI is mandatory for all scoliosis patients, irrespective of whether it is idiopathic or congenital, because even in idiopathic scoliosis, the reported rates are about 20 to 40% of spinal dystrophism, which can be present in idiopathic scoliosis, whereas in congenital scoliosis, it can go up to 80% of the times. So these kind of uncommon curves, you have to be very, it is very crucial to do these tests to rule out the things.
Yeah, to summarize, when on clinical examination, if you have clinical signs suggesting spinal dystrophism, or if there is an uncommon curve pattern like a left thoracic, or you find some neurological findings like asymmetrical abdominal reflexes or exaggerated reflexes. These are the situations where an MRI must be done. But in general, nowadays, an MRI is recommended for all scoliosis patients, especially if we are considering surgical treatment. Okay, Sudhir, please go ahead.
So you can divide into skeletally mature and skeletally mature. Again, it can be divided into less than 20 degree, 20 to 40, and greater than 40 degrees. Less than 20 degrees in skeletally immature, just observe every 6 months till the patient attains skeletal maturity, and nothing needs to be done, just observe. 20 to 40 degrees, you can advise orthotic treatment in the form of TLSO or CTLSO, that is Milwaukee brace or Boston brace. And usually when you advise orthotic treatment, it has to be worn for about 23 hours a day, except for the time of bathing and during bathing and toileting purposes. The child has to wear it even in the night, which is very cumbersome, and most of them will come back to you with as defaulters. So orthotic treatment is quite difficult. Greater than 40 degrees, you have to go out with surgery. Now coming to skeletally mature, less than 20 degrees, no treatment. Most of these curves will not progress. 20 to 40 degrees, you can take X-rays, serial observation for every 3 years. Greater than 40 degrees, surgical treatment. Now I'll come to the surgical treatment options for these patients. In immature children, as I already said, there are 2-3 reasons why you should not fuse the spine in immature children. Those who have not attained skeletal maturity, because number one, it will result in stunted growth. Number two, thoracic cage. We will restrict the thoracic cage and the space available for the lungs to expand. So we have to give all the chance for it to attain its maximum stage. And number three, to prevent crankshaft phenomenon. I'll discuss what is that now in the next slide. So the option which is commonly available is growth rod technique. So if you are coming across a child with infantile or juvenile idiopathic scoliosis greater than 40 degrees, you can advise growth rods. That means you don't strip off the entire thing. You just dissect over the proximal and distal part, and then you place rods and connect with something called as dominoes or rod-to-rod connectors. And every 6 months, you have to call the patient and you have to lengthen the rods. It is an operative procedure. You have to open and lengthen the rods. You have to make sure that you're not damaging the facet joints, because the moment you damage the facet joint, the spine will fuse. So dissection in these patients is very, very crucial. Muscle stripping should be minimum. Facet joints should not be touched in these patients. Otherwise, the spine will fuse and the entire principle of growth rods will be lost. Crankshaft phenomenon is nothing but, suppose if you're fusing a child posteriorly, the anterior part of the spine or vertebra will still be growing. If it grows, what will happen is again the spine will tend to rotate towards one direction, towards the convexity, and again the patient will come back to you with recurrence of deformity. That is why, if you remember in the initial slide, the table which I put from Campbell, they would have given, if it is 8 to 11 years, always do anterior plus posterior fusion. If you feel the curve is significant, if it cannot be treated with growing rods, then you go for both anterior and posterior fusion. Posterior fusion alone before attainment of skeletal maturity is risky, and they come back to you again. The various authors have stated these parameters as predictors of crankshaft. So you have to do anterior plus posterior surgery and fuse the spine 360 degrees whenever it is riser 0 or 1, tanners less than 2, and when the three-dimensional rotational deformity is very significant, that it is not being corrected even by heavy instrumentation, posterior maneuvers, then you can go ahead with anterior plus posterior. Now, what are the risk factors for progression in idiopathic scoliosis? Girls, being a girl is a risk factor. Premenarchal skeletal maturity, definitely a risk factor. Risers grade 0, a risk factor. Double curves and thoracic curves are risk factors. Whenever you come across double curves, they can progress. And of course, the time of presentation, at the time of presentation, if it is 60 degree or 70 degree curve, definitely they will progress faster compared to a 30 degree curve or a 40 degree curve. This chart is very, very important. It denotes the peak height velocity. It is a series of height measurements which you make on the basis of centimeters per year. It usually ranges between 8 to 9 centimeters for girls and females. The peak height velocity is one indicator after which you can undergo a definitive procedure. That means the crankshaft phenomenon usually will present if there is peak height velocity if it is not attained. And there will not be a crankshaft phenomenon if peak height velocity is attained, because studies have clearly shown that razors, menarche, triradiate cartilage closure, everything happens after peak height velocity. So if you feel that the peak height velocity has been attained, then you can go ahead with posterior alone procedures and the chances of crankshaft is very less. Now, the next question is, you are going to do surgery for a skeletally mature idiopathic scoliosis. What are the treatment principles? It is definitely a very, very vast topic. It itself can be discussed for one whole day. If you have time, and if some of you rarely, it's a rare occasion for some of them to be interested in spine, that too in scoliosis. If you are interested, definitely you can go through this review article published in JAOS. It is a very fantastic article, just 6 or 7 pages, how to choose the fusion levels in AIS. It will be given in a very clear and concise way. Based on that, we will fuse. But the general principles, I'll talk only about the general principles. The major curve and all the structural minor curves should be fused. If a minor curve is non-structural, then you need not fuse it, because it will get corrected by itself in the due course of time. This is the general principle. What are the other principles? Whenever you are exposing, adequate lateral release is the key for any surgery, for any scoliosis surgery. The more you release, the spine will get corrected. You should not hesitate in lateral release. You should not think that you are stripping going near the ribs in the thoracic area. You have to release as much as possible safely without injuring the pleura. Maximal screws should be put at the concave apex. Putting screws on the concavity, pedicle screws on the concavity is very, very difficult. But however, you have to use C-arm or O-arm or whatever technology you have, you should use that, and maximum screws at apex is important. Multiple level facetectomy, it is just, you have to knock off all the joints to make the spine mobile. You have to knock off all the joints, only then you will be able to correct the spine according to your will and wish. Then comes rod translation. That means you place a rod and you pull the rod towards the spine to correct the deformity. The next thing is something called as cantilever bending and rod rerotation technique. Cantilever bending is, you contour the rod according to whatever contour you want. Suppose you want thoracic kyphosis and lumbar lordosis. Suppose you want a 40 degree of thoracic kyphosis and 40 degree of lumbar lordosis. You contour the rod like that. Then you place the rod over the spine and try to bring that rod towards the spine by using various reduction instruments. By doing that, the spine will get adapted to the rod's contour. The next mechanism is rod rotation. You place the rod according to the contour of the scoliosis curve. Why I have put this bucket symbol is, basically what you're doing is, you are trying to convert the scoliosis in the coronal plane into kyphosis in the lateral plane. So you are rotating the spine. It's a rotational deformity. You have to imagine a 3-dimensional way. So you're rotating the deformity. Thereby you are bringing the bucket handle from one dimension to the other dimension. So you can rotate and derotate the rod, thereby correcting the curve. And the last technique which you can use is direct vertebral rotation. It is nothing but you have specific instrumentation for that. You put the pedicle screws, you attach the pedicle screws with the DVR device, by which you can individually rotate each and every vertebra. By that, you can achieve good vertebral derotation. These 4 points you have to by heart. It is very, very, very important. There are lots of concepts behind each and every point, but this is very, very important take-home message. Distraction from the apical vertebra on either side of the curve will create kyphosis. As I said, it's a 3-dimensional deformity. So if you're doing something in the coronal plane, it will have an impact on the sagittal plane also. Distraction will cause kyphosis. Compressing towards the apex of the curve will cause lordosis. Just imagine you are compressing it, you are compressing the screws. Automatically when you are compressing, there will be lordosis which is forming. Suppose if you have to create kyphosis, you feel that in the preoperative X-ray, the kyphosis is less. You want to give some amount of kyphosis. Always approach the concave side first and give distraction. You will create kyphosis. Suppose if you feel, no, I want to create lordosis, it is hyperkyphotic, then always approach the convex side first. If you're able to remember these 4 points as basic principles, it is okay. Otherwise, just forget it. It's just basic 4 points. So these are the basic steps in scoliosis surgery. You expose, knock off the facet joints, put pedicle screws, release, place the rod, derotate the rod, compress, distract, and then align and place bone grafts and close. So this summarizes the 7 to 10 hour surgeries that we do for scoliosis. So this is the example which we discussed earlier. So this is the intraoperative view. You can see the scoliotic deformity after various screws which has been put in. So first I usually try to place, stagger the screws. That means top and bottom you should have good amount of pedicle screws, and in between you can stagger the screws. That is called as low density instrumentation. You need not put pedicle screws at all levels. That is not required. However, the top and bottom portion should have at least two vertebra. The screw should be in at least 2 vertebra above and 2 vertebra below the construct. And then you do rod derotation and pack with adequate bone grafts. So this is the post-operative X-ray. The ultimate aim of any post-operative X-ray is the arrow mark which I have drawn in the center, the white color arrow mark. Even if there is a curve, you need not bother. But if the coronal compensation is good and the shoulder balance is maintained, that is more than sufficient. So this 100-degree curve came to 31 degrees and proximal thoracic came to 25 and lumbar curve became almost straight. This is the clinical picture of the patient. Last few slides about neuromuscular and congenital, last 3-4 slides, then we'll wind up and we'll start a discussion session. So neuromuscular scoliosis, you need not by heart all these things. It could be myopathic, it could be because of neuropathic causes. Principles of neuromuscular scoliosis. So how it is different from idiopathic scoliosis. Most of the times idiopathic scoliosis patients comes to you with the complaints of cosmetic deformity. So the aim of surgery is you become a cosmetic surgeon. The aim of surgery is to give a balanced spine over a balanced pelvis with a balanced shoulder. Whereas in neuromuscular scoliosis, you should understand your entire aim is different. Your goal is different. You have to make the patient sit and mobilize. The patient will not come to you with cosmetic deformity in neuromuscular. It is mainly to make the patient sit and mobilize with a stable pelvis. So always long segment fixation is required. You should anticipate increased blood loss. Pedicles will be very dysplastic in neuromuscular. So you should be prepared to use sublaminar wires. That is, you use wire under the lamina and try to hook it around. Adequate bone grafting, much more than idiopathic scoliosis, is required because pseudoarthrosis and failure rates are very, very high in neuromuscular. And you have to be ready with increased perioperative complications. The anesthetic should be worn. One most important thing which I want to point out in neuromuscular scoliosis is about pelvic obliquity. Most of these patients will have pelvic obliquity. The pelvic obliquity may be fixed or may not be fixed. Suppose if the pelvic obliquity gets corrected with abduction or adduction of the hips, it means that the pelvic obliquity is not fixed. In those cases, you need not include the pelvis with your fixation. Suppose whatever you do, the pelvic obliquity is not getting corrected, it means it is a fixed pelvic obliquity. In those cases, it is important to include your instrumentation into the iliac bone also. You have to, that is called as spinopelvic fixation. You fuse the spine with the pelvis. Otherwise, again, the pelvic obliquity may worsen and your entire aim or goal, as I already said, which is to mobilize or make the patient sit, will be gone. So that is very important point. Cerebral palsy, I wanted to cover these slides because it is given in Campbell. So just 1 or 2 slides. This is by Longstein Cabernia classification. Type 1 is double curve with no pelvic obliquity. Type 2 is large curve with severe pelvic obliquity. And again, the principles are same. Last 2-3 slides about congenital scoliosis, and then we'll go ahead with case discussion. It could be because of failure of formation It could be a wedge vertebra, incarcerated vertebra, or multiple wedge vertebra, or it could be failure of segmentation. That is, the vertebra would have been formed, but the next process of formation during embryologic development is segmentation. Each vertebra has to segment itself. So if there is no segmentation, it is called as failure of segmentation and mixed deformity. So this is a very, very important table, and it is a landmark paper by McMaster et al. It was published few years back, 20, 30 years back. They actually diagnosed, they actually described few curves which has the worst progression and few curves which will not progress in a significant way. And this is one of the most important MCQs in all the entrance exam also. Any patient with unilateral unsegmented vertebra bar and a contralateral hemivertebra, they have the highest propensity to progress further. So they have to be addressed immediately and in a proper way. That is very, very important. Because the hemivertebra will tend to grow, whereas bar will tether the spine and it will not allow to grow. So one side will keep on growing, the other side will not grow automatically. The curve will progress much more faster, and they are notorious curves. The treatment principles, again, the goal of treatment in congenital scoliosis is number one, if there is any spinal dystrophism, this is thumb rule. Any spinal dystrophism, spinal cord anomaly like spinal diastematomyelia or tethered cord, first that has to be addressed. Scoliosis comes secondary. Do not go with scoliosis correction. So MRI is mandatory. Only if the spinal cord is normal, you go ahead. Otherwise, you call the help of the neurosurgeon. They have to look, they have to correct the spinal cord anomaly, and then your role comes as a orthopedic spine surgeon and to correct the deformity. In case of congenital scoliosis, it is very, very important. You have to intervene at the earliest as possible, because as early as possible, because the curves will progress very fast, and if you miss it, then you will be in trouble in future. It is very difficult to correct at a later stage. Whereas if you find it in a 5-year-old, a hemivertebra, in 3-year-old, 4-year-old, you can just do a hemivertebra excision and you can correct the curve, which is a very straightforward, simple procedure. Compared to the same patient coming to you at 15 years with a gross scoliosis, rigid scoliosis, it is very, very risky to correct at that stage. If you want to prevent any deformity, if you feel the deformity is acceptable, but I want to prevent it, then you do in situ fusion only at the level of the deformity. If you want to correct, then you can use something called as hemiepiphysiodesis, just like you do in Blount's disease and other long bone deformities. You do epiphysiodesis, that is fuse on one side of the vertebra which is growing, so that that side is not growing and the curve will compensate. Or you can use growth rods, as we discussed earlier. Vector is one technique which is not very commonly used in our country, except for AIMS, they use this. And it is vertebral expandable prosthetic titanium ribs. So it is a complicated procedure whereby you use to expand the thoracic and rib cage along with the spine. If you want to correct the deformity in an acute way, not by a gradual means, like as I said, hemivertebra excision. If there is a curve, small curve because of hemivertebra, go just remove the hemivertebra, correct the curve, put 1 or 2 screws above and below and correct it. And if you want if you feel the curve is very severe, 50-60 degrees at the time of presentation, you cannot wait for gradual correction, then you go ahead with anterior and posterior spinal instrumentation for congenital scoliosis, because the chances of progression is very high. So with this, I think we have come to the end of the session, and we'll start the discussion and the questions, and these will be the suggested learning. According to me, if you are able to read the 200 pages in Campbell, you can forget about the operative procedures part. If you see in Campbell, most of the pages will be the surgical procedures. You need not get into the surgical procedures per se, how to do or how to correct or how to each and every procedure they would have explained in detail. You need not read all those things, the boxes. You have to just read the rest of the part. It is more than sufficient. And sometimes you may get, or if you are interested in the recent advances, you can read these 2 papers which I have already mentioned. This is more than enough for scoliosis, and you need not refer any other books or any other papers for scoliosis. Yes, Dr. Phani, we can have.
Thank you, Sudhir. It was quite extensive. You covered the evaluation of scoliosis, and actually you made it quite simpler for the PGs to understand also at the same time. It's a difficult task, and you have done a good job. What I would just like to summarize is when there is a case a PG has to evaluate in the exam. If they are able to basically, based on the history and examination, to differentiate it from into the one of the three broad categories as congenital, neuromuscular, or idiopathic scoliosis, and then describe the radiological assessment and the balance and the severity and the level of the curve, and mention the important classifications that you mentioned. I think that should be fair enough for them to score good in the exam. Anything more than that would be, more of a distinction category. So I think you are going to show us some case examples now, or
no?
Let us see if there are some questions from the audience.
Sudhir, wonderful presentation, Sudhir. Yeah, wonderful presentation. So I think it's a very difficult topic. I do understand, like what Dr. Kiran said. There are a lot of pictures, a lot of angles. Okay, a lot of progression. So many other things are there. I think as what Kiran said, I think if they can keep it very simple, let them not go into advanced level. They have to go and read whatever you've taught. If they go and read, okay, and then again listen to your topic in YouTube, I think that will be I think that they'll have to be very clear about it. Now you've given that's just eye opener or an eagle's eye view you've given. I think they have to, each one of your slides is per se to be understood. Every slide is very important. I request the PGs to go read it and then again listen to each of your slides. I think then that will be the best for them. I think we have few questions. I think Kiran will take over. Yeah.
Okay, so what is magnetically induced non-invasive scoliosis correction?
Yeah, yes, it is called as the magnetic rod technique. It is a form of growth rods for early onset scoliosis when they have not attained skeletal maturity. And I am emphasizing this fact again, when you want thoracic cage to be left open for the pulmonary development, you use something called as magnetic rods, wherein the difference is in growing rods technique, you have to get into operation theater, open up the patient, and every 6 months you have to keep on doing that. Whereas in magnetic rod technique, it is using the magnetic phenomenon. You can just try to distract the rods by using this therapy. However, it is practiced in very few centers, and as far as I know, only very few centers, handful of centers in our country they do, and it is not very common here. It is a very, very financially also it is a very costly procedure, but it is a good technique for early onset scoliosis, similar to growth rod techniques.
Yeah. Sudhir, one thing I wanted to ask you: what happens to the pulmonary function of these patients? When you contemplate surgical treatment, what is your aim of surgery in congenital scoliosis versus in idiopathic scoliosis with regards to pulmonary function?
Yeah, whenever these patients come to us, one of the most important things again that we have to examine in these patients is single breath count. So usually the difference in idiopathic and congenital is the idiopathic patients, they will not have any significant difficulty in single breath count, or they will not be breathless. Whereas in severe congenital scoliosis, the patient, they will not be able to talk to you or converse with you comfortably, and they will be having breathlessness. And usually the normal single breath count is about 1 to 30. They will be able to count 1 to 30 comfortably. Whereas in congenital scoliosis, hardly 10 to 15, it is very difficult. Whenever you have this kind of phenomenon, immediately you have to ask for pulmonary function test. Even otherwise, any scoliosis patient, make certain things mandatory, like MRI, it is mandatory, and pulmonary function test, it is mandatory. Neuromonitoring for surgery, mandatory. These things should not be compromised at all. So do pulmonary function test. In congenital scoliosis, most of the times they will have restrictive pulmonary disease because the thoracic cage is collapsed. So by operating, what you do is you derotate the spine and you actually remodel the thoracic cage. Thereby you give space for the lungs to expand. So the breathlessness component will come down and the lung will have good space. The post expiratory volume, everything will increase in these patients. So that is very, very important. Suppose if you feel that the pre-operatively the patient's pulmonary function is very poor, then you have to train the patient before surgery. You have to ask them to improvise their breathing ability. You have to teach them deep breathing exercises for 1 month or 2 months. You have to ask them to keep blowing balloons, at least 50 to 100 balloons per day, so that their lung function expands. Because surgery per se can compromise the lung function. Again, it can result in lung collapse. So all these things have to be taken into consideration when you are planning for surgery in these patients.
Great, that's a good explanation. There's one question here. What indications for intervertebral stapling?
Yeah, intervertebral stapling is nothing but hemiepiphysiodesis. That is what I mentioned as hemiepiphysiodesis. Usually it is being done in congenital scoliosis. So whenever you come across a curve which is going on one side and it is in the early stages and you want to prevent it from growing, you just go ahead and staple it. It will result in hemiepiphysiodesis on that side. So that side will not grow, whereas the opposite, it will compensate for the growth arrest on the opposite side. But it has there are papers which have shown that the staples have come out and it has injured the pleura and the vital structures. So again, it is not being used very commonly.
And what is the role of serial casting or bracing?
Yeah, serial casting or bracing techniques are there. For congenital scoliosis, the role is almost nil. The role is almost nil. It won't help significantly in congenital scoliosis. As I said, it is because of the structural anomaly of the spine. So by giving brace or by cast, it is not going to alter the structure of the vertebra or the growth process of the vertebra. So for congenital scoliosis, the literature is very clear. Casting and bracing, its role is very, very minimal. Whereas for idiopathic scoliosis, especially in juvenile or adolescent or infantile type of scoliosis, previously people were using casts, but it is a very, very cumbersome process. You have to cast the entire spine by giving corrective maneuvers, 3-point pressures, and the child has to be in the cast for very long, prolonged periods of time. Then came the braces to avoid the complications of cast. So braces, again, it is based on 3-point pressure. And the disadvantage of braces, the child has to wear brace for almost 23 hours per day. Except during toileting purposes, the brace has to be worn completely 23 hours per day. And you have to take serial x-rays every 6 months. And at the end of 1 year, if you feel that the curve has not progressed greater than 3 degree to 5 degree, then you can reduce the timing of brace to 12 hours. For next 1 year, the child has to be in brace for 12 hours. But all these things is practically very difficult, and the child will not be very appreciative of this, and the patients will not be very cooperative for this. With the advent of pedicles, see, all these techniques were used initially. If you see the history of treatment of spine pathologies, especially deformities, initially before the advent of pedicle screws or advanced instrumentation system, they didn't have any proper instrumentation to control the rotation of the spine, because it is a complex structure with so many vital organs in front and in the sides. But with the advance of pedicle screws, you put the pedicle screw, you have advanced instrumentation techniques, you can correct whatever you want in whatever way you want. All these bracing and casting has come down gradually. It has come down. But definitely, for exam point of view, you should know Milwaukee brace, Boston brace. Any scoliosis with apex below T8, you can use TLSO, thoracolumbosacral orthosis. Any scoliosis with apex above T6 to T8, you have to use even cervical support. Thoracolumbosacral orthosis will not work because the 3-point pressure should be even more at the top. And one more most important point, bracing should be custom made. It has to be properly done by a proper orthotic person, which has to be custom made with proper measurements at each and every level, at the nipple level, at the abdominal waist level, pelvis level, and then proper molding should be done. Otherwise, brace will not work.
Yeah, good. So there's another question. During correction of scoliosis surgery, how to avoid stretching of the nerve roots?
Yeah, very, very
Get
vital
into that, this gets into the treatment part and the problems we face in the treatment. But yeah, you can answer this.
Yeah, it's a very, very vital question. As I said earlier, neuromonitoring has become mandatory nowadays. Since it is quite commonly available, if you're doing a scoliosis surgery, you have to have neuromonitoring. Initially, people used to have wake-up test. You have to inform the patient beforehand that we will wake you up in the middle. You should obey our commands. The anesthetist will explain. And once you are doing the rod derotation mechanisms and when you are fixing the curve, then at that time, after that, the deformity correction, the anesthetist will wake up the patient and ask them to move the toes. But now neuromonitoring has two things, SSCPs and MEPs. So what happens is when you are doing the correction, you have to be gradual. You have to be very slow. Putting pedicle screws usually will not injure the cord unless you are grossly wrong and unless the screws are into the spinal canal and injuring the cord. Sorry, I missed the question. How to avoid stretching the nerves? Yeah. So it has to be number one, gradual correction, sequential correction techniques. You should not be very aggressive and you should not put the rod and immediately derotate the curve like this. It has to be very gradual, sequential. Suppose if you are using cantilever bending mechanism, like if you are bringing the rod to the spine, you have to bring it very slowly, one by one. You should not just put 2 or 3 towers in the rod and come and jack it up, because the spinal cord will immediately rotate or with the with the vertebral column, and it can result in profound deficit. And the next most important thing is at any point of time, you can get drop-in signals because of stretch of the cord or the nerve roots. Whenever you are getting a drop in the spinal cord signal in neuromonitoring, immediately you have to stop and immediately you have to remove everything. In the sense, you have to decorrect everything. Whatever correction you have done, you have to loosen the screws and you have to loosen the rod. And again, you have to wait for the signals to come back. If the signal comes back, then again you can do it slowly. But the most important thing is you have to ask the anesthetist and the neurophysiologist who is doing the neuromonitoring that the proper anesthesia is being given. Inhalational agent should not be used. Usually it is in the form of TIVA, that is total intravenous anesthesia, like they commonly use propranolol. What is that? That white thing.
Propofol
for that, and that is very, very important. TIVA is very important. Inhalational agent should not be used, and both SSCP and MEP should be monitored. Temperature should be optimal. Sometimes temperature differences can result in signal drop. All these things are very, very important.
Sudhir, yeah, that's a good summarization of the precautions that we take. Just wanted to add that in this question, one should anticipate the possible cord problems by looking at the severity of the curve. When the curves which are more than 70, 80 degrees or 90 degrees, they are the ones which are more likely to develop deficit while correcting than the milder ones, the ones between 40 to 60. So when there are severe curves, to avoid overstretching the cord, we sometimes do some anterior column shortening procedures, so that the cord doesn't stretch. So that gets into more detailed treatment options. But the PGs in general should understand that in severe curves, to avoid overstretching the cord, one should anticipate the possible neurological deficit, and as you said, neuromonitoring should be used. And anterior column shortening techniques are an option which are used in more severe curves to prevent overstretching the cord while correcting the deformity. One more question here. Do's and don'ts for an adolescent idiopathic scoliosis patient in a patient between 20 to 40 degrees. Do's and don'ts. For the patient, you mean?
Yes, do's.
Maybe he means that what would you instruct the patient?
Yeah.
The ones who are in 20 to 40 degrees. What would you tell the patient?
Yeah. Instruct a serial observation every 6 months with X-rays. And you can advise orthotic treatment for these patients. If the patient is cooperative, you have to explain very clearly about the bracing, which we have discussed in detail. And every 6 months, the patient has to come with you with the follow-up X-rays. You have to keep record of all the X-rays. And if the curve is progressing in a very significant way, then you have to tell them that the patient will require some kind of operative procedure. And you have to clearly explain them that if the patient has not attained skeletal maturity or menarche, if it is a female child, you have to tell them just before menarche or just before peak height velocity, there will be acute worsening of the curve. Suddenly there will be a curve progression and the shoulders may droop and the curve may become significant. In those cases, you have to ask them to come again every 6 months and then you have to monitor them. Otherwise, there is no specific do's and don'ts. They can be just, as I said, idiopathic scoliosis, especially adolescent, they come to you for cosmesis. There won't be any lung function problems or neurological problems or pain or anything. It will be for cosmesis. All rest of the things are secondary phenomena that we explain to the patient that if we do not intervene, the curve may progress, the patient may develop early degeneration at a later age or may develop some kind of neurological impairment at a later age. But the patient's criteria will be cosmesis in adolescent idiopathic scoliosis.
Yeah, that's an important point. Cosmesis for adolescent idiopathic scoliosis, prevention of severe deformity and the prevention of pulmonary restrictive function in congenital scoliosis, as well as neuromuscular scoliosis, and improving the sitting balance and function for neuromuscular scoliosis. These are the aims of surgical treatment in treating scoliosis. There was one simple question. We'll just quickly answer this. Is it mandatory to do a pulmonary function test pre-operatively? I think Sudhir has already mentioned it in the talk, and we discussed that pulmonary function test, yes. Anytime when you're contemplating surgical treatment, it is mandatory, especially in congenital or neuromuscular scoliosis. How much degree of curve progression every 6 months is significant?
Usually,
regarding the...
Pardon?
Yeah, go ahead, Sudhir.
Yeah, usually in case of adolescent scoliosis, the normal rate of progression is about 1 to 2 degrees per month. That is the normal rate of progression. Suppose if the curve is progressing beyond that, for example, for 6 months, you can say 10 degrees. That means it is a significant progression rate for adolescent idiopathic scoliosis. But again, that depends on the type of scoliosis. For infantile juvenile, it is totally different. For congenital, it is totally different. And for adolescent idiopathic, it is totally different. But roughly, you can have 8 to 10 degrees for adolescent idiopathic scoliosis every 6 months.
Yeah. And I think as long as they are below 40, you can still keep watching, because surgical treatment, usually we do not operate when they are below 40 degrees. Yeah. So any more questions?
Yeah, there is a question for me. Importance of neuromonitoring device during surgery. Yeah, as mentioned earlier, neuromonitoring is mandatory for any deformity corrections, especially scoliosis and kyphosis. Very, very important and mandatory when you're dealing with some congenital scoliosis. It can be divided into two aspects: SSEPs, somatosensory evoked potentials, and motor MEPs, motor evoked potentials. So the importance is, it is a real-time monitoring of the neural structures. Whatever you're doing, it is depicted in the neural monitor. Though there is some lack of few seconds or minutes, 1 or 2 minutes, it is very important. For example, you're de-rotating the spine, or you're doing some corrective maneuvers by rotating the spine or by doing some vertebral rotations. The spinal cord inside the spinal canal, it should accommodate your rotational maneuvers. Sometimes the cord may not accommodate, the cord may not adapt to it. The cord may suddenly go in for a state of shock. That may result in drop of signals. So once the neurophysiologist who is monitoring the signal says that there is a drop of signal on the right side or on both lower limbs, immediately you have to stop, which means that the cord is not getting adapted to your maneuvers. And then you have to you have to undo whatever you have done. And you have to release the screws, rods, and then wait for the signals to come back, and then you have to proceed. So it is very, very important. Suppose if you don't have neuromonitoring, you will correct and the curve may look straight from 100 degrees, you would have brought it to 10 degrees or 0 degrees. but the cord would have not adapted and the patient would have developed complete paraplegia. And it is sometimes irreversible if the patient develops that. If you have neuromonitor, there is a chance, scope or window of hope wherein you can undo certain things and it can come back.
Yeah, that's right. Good. So the most important thing Dr. Sudhir mentioned is when there is a drop in neuromonitoring function during surgery, it's important to reverse the last done step which has caused the drop, and also look at the physiological parameters, the temperature and the anesthesia, depth of anesthesia, and the blood pressure. And usually, most of the times it the function comes back, and we can have a lesser acceptable correction. Right. I think, are there any questions regarding the assessment, more clinical assessment and the radiological assessment and the angles that is more important for the PGs? I think we have been discussing too much on the treatment. Yes, that is important, but for PGs, for the exam purposes, I think we'll take questions now more on clinical assessment and evaluation. Any doubts in that part?
As Dr. Phani Kiran said, it is very, very important on the clinical examination and the investigation and x-rays. It is very, very important because your entire treatment, everything depends on the x-ray measurements. And
there is a question, CT scan, role of CT scan.
Yeah, CT scan, as we all know, it gives us a clear picture of the bony landmarks and the bony structures. In scoliosis, it is very, very important to have CT scan because you have to know the size and shape and the orientation of the pedicles. Usually what I do is, whenever I come across scoliosis case, I go and sit in the packs and look at each vertebral level and look at the orientation of the pedicles and the size of the pedicles. Concave pedicles will be very, very dysplastic and small. So you have to be prepared, and proper preoperative planning is very, very important. You have to mark the pedicles where you are going to put screws, and you have to go to the CT scan and look whether these pedicles are all right and whether you are able to, whether you will be able to use those pedicles to put screws. And again, not only that, you can just delineate the entire structure and you can use the 3D reconstruction views to see the deformity, and you can plan your osteotomies and release and the rotational maneuvers to correct the spine, basically to look for the pedicles.
Yeah, and in case of congenital scoliosis, CT scan does help us to get a more clear picture of what exactly is happening, whether there is what is the defect of segmentation, defect of formation, or there is a mixed combination of hemivertebra with a unsegmented bar. So that gives us an idea about the potential for severe deformity in congenital curves. So apart from what Dr. Sudhir has mentioned, CT scan is very important for congenital scoliosis to understand the potential of severe progression.
Exactly. So very, very important for congenital. There is a question to me, is it mandatory to take MRI brain to rule out any pathology in brain like Chiari malformation? Arnold Chiari malformation, usually if you do MRI whole spine, you will be able to find out whether there is any Chiari malformation in the brain, in the upper cervical spine and medulla. Otherwise, MRI brain need not be done as a routine to evaluate scoliosis. MRI brain is not required. MRI whole spine is more than sufficient.
Yeah. Another thing that we see in the CT scan is when there is a diastematomylia, when there is a split cord, sometimes there is a bony spicule in the center dividing the spinal canal. And so that is an important aspect because the spinal cord is tethered by that bony division of the spinal canal, and it always needs to be tethered and released by the neurosurgeons before we go ahead with the scoliosis correction. Question about at what age it is better to operate? Well, it depends on various factors.
It depends on various factors, like Dr. Phani Kiran told. Congenital scoliosis, earlier the better. The moment you see congenital scoliosis, do all investigations. Try to find what is the type of scoliosis, what is the type of the congenital anomaly. Suppose based on the chart which I showed you, suppose if it is going to be just a block vertebra, two vertebra fused together, nothing needs to be done. It will not progress. Whereas if it is going to be a hemivertebra, definitely it will progress. You have to intervene as early as possible. So basically it depends on the type of scoliosis. Congenital scoliosis as early as possible. Again, based on what type of congenital anomaly. Idiopathic scoliosis, wait as much as possible till skeletal maturity is attained. If you feel that the scoliosis is progressing very rapidly at 10 years itself, if you feel that I can't wait till 13, 14 years, then go ahead and do some kind of growth modulation procedures like what we were discussing, like growth rods, till the patient attains skeletal maturity. Give some time for the patient to attain some height. Otherwise, the patient will be stunted in growth. Otherwise, wait till skeletal maturity or menarche or peak height velocity and then operate. So depends on the type of scoliosis.
Yeah.
So
Sudhir, one point I want to add. In a congenital scoliosis, like you said, yes, the earlier the better. But one thing that is very important for the PGs to understand is one must assess the potential of progressive deformity in congenital scoliosis. When there is a hemivertebra, sometimes it may not be so progressive or it may not cause any harm. But whereas some very innocent looking hemivertebrae may rapidly progress. So one thing that is important is do not consider surgery at the first visit when you see a congenital scoliosis. Always document worsening. You take serial X-rays with a gap of 6 months at least, and make sure that the vertebra, see how it is behaving. If it is progressing rapidly, then yes, consider early surgery. But if it is not at all worsening, and sometimes there may be even correction also. So one important thing is do not jump into surgery on the first visit in congenital scoliosis. Operating early is important, but documenting
progression
is important.
Yes. So documenting progression is very, very important. So everything depends on the rate of progression of the curve, type of curve and rate of progression. That is very, very important. So suppose if you are seeing progression and even if the child is 5 years of age, you should not think that you should wait till skeletal maturity. If the curve is progressing and your by serial X-rays, and even if the child is 4 years or 5 years, you have to go ahead and use the appropriate treatment modality and operate the child.
One important thing in assessment of congenital scoliosis is it is more likely that they have congenital problems in other systems of the body, like cardiac or renal or pulmonary. So, and they may also have some other limb deformities. So it's important to assess these patients in that angle as well, especially if you're considering surgery.
Correct.
Any further questions?
Sudhir, I think it was very exhaustive.
Yeah.
I also thank Phani Kiran for wonderfully moderating the session, and you have to add a lot of points. And so I request Thanapan sir, இருக்கீங்களா sir? Thanapan sir, he's there online. On பண்ணிருக்கு. I think maybe he's just left. Okay. So thank you, Sudhir. Thank you for for first accepting both of you, Dr. Phani Kiran and Dr. Sudhir. So it was a wonderful session. I know it was a very, very difficult topic. I understood, the way that each and everything was explained. So the PGs, I think they've got an idea now. I think we'll have to refresh with a very short, some case presentation or something like that with the scoliosis. So they'll be able to understand. So I once again thank on behalf of TNOA, for making this complex subject little easier. And also I thank Dr. Phani Kiran for accepting our invitation and moderating wonderfully. Phani Kiran, last time when I saw you, I think you were without a mush. I think it is the you spotted new mush, which you're looking more like a Telugu actor. And so
nowadays it's all hidden behind the mask, so I can try anything.
yeah. So it looks good too. It looks good also. So thank you both of you, and I also thank Alembic for having been the technical support. So they've been behind us throughout the week. So I also thank them. And I also thank the PGs for having attended the class. So I request them to go and read back immediately for them to, remember this highly volatile subject. And so if you read that immediately, you will be able to at least grasp and remember whatever has been told today. So thank you so much, gentlemen. Thank you. Wonderful session we had. Thank you. Thank you so much.
Thank you
Yeah.
for the
Ramesh, thank you, Ramesh. Thank you, Ramesh. Yeah, we'll
thank you,
close.
sir.
Thanks,
Yeah.
thanks. Bye. Bye.
Bye.